Welcome, everyone. I'm talking to you guys about oppositional defiant and conduct disorders today. I want to give a shout out to DC PAP and all the amazing services provided. So we do these monthly trainings. If you miss one, there is a library of our previous trainings. We could offer practice-based trainings if there's something your practice wants to learn more about. We also keep a warm line 8 to 5 Monday through Friday where you can call with consultations, speak with a psychiatrist, or also resource referral support. Then we have office hours 12 to 2 Tuesdays and Thursdays where you can pop in with a question, listen to other people's questions, have a topic you want to know more about, come ask us. I have no financial disclosures. This is the CME slide. You can get CME for this. We'll send out the slides, so you'll have this and spend much time on it. So my goals today, I want to give you guys a little bit of context for ODD and conduct disorder. I think these are disorders that don't fit the typical medical model, and so sometimes they're difficult to integrate with traditional medical training and practice. I want to look at some clinical pearls, how I go through a differential, and then number 3 is probably my most important. I want to encourage you guys to see, when we're considering kids for this diagnosis, see this multi-dimensional model of biological, psychological, and social factors that contribute, and then look at some prevention and treatment options. So why are we talking about this? So if you have a quiet, sort of internalizing, anxious kid, this is, problematic, but not as overtly distressing as a kid who is externalizing and disruptive, right? Everyone sees this, society has a problem with it. And so this is why we get referrals, honestly. And this has been true sort of forever, that disruptive behavior has been the most common reason for referral, and thus it's the most heavily studied aspect of child psychiatry. So these are valid and reliable syndromes. I did want to talk a little bit about the child guidance movement. I'm a history person. So in the early 20th century, we had all of these juveniles that we were incarcerating with adults. And there was some great advocacy from a lot of different disciplines. So teachers, social workers, judges, pediatricians, and psychiatrists all sort of came together and said, do we think it's possible that things that are happening to kids are the reason they're ending up becoming offenders? Is there a way we could treat them differently than we're treating the adults? And so this was the founding of juvenile justice. And within juvenile justice court, child guidance clinics were set up. And so that's where the first child psychiatrist practiced. So this is why child psychiatry is sort of an offshoot of adult psychiatry instead of a pediatric subspecialty. So the sort of adult psychoanalysts started applying their theories at the time to the kids in the child guidance clinics. And so this sort of focus on disruptive behavior and prevention and presence from a forensic perspective has been a big part of the legacy and founding of child psychiatry. All right, so first I'm going to talk to you guys about ODD, oppositional defiant disorder. This is the more benign of the disorders we're going to talk about. We cluster in 3 different types of symptoms. So angry, irritable, these are the kids you sort of walk on eggshells around. So if they don't get their way, they're going to be really upset, they're touchy, easily annoyed, lots of outbursts. Argumentative and defiant behavior, this is sort of the classic ODD symptoms. Kids that, the teacher says, everybody line up, and the kid says, make me. So they might just ignore your requests, blame other people when they do something wrong. They're not going to compromise. It's my way or the highway. The third aspect, vindictiveness or spitefulness, is more severe in terms of symptom paradigm. This is more associated with development of things like conduct disorder and antisocial personality disorder. I do want to caveat that negative behavior is expected as part of child development. So kids need to be able to say no at times as they find their autonomy and decide what are the limits. How are grown-ups going to react to me? So we always say every behavior has some sort of function. And there is a sort of bimodal peak of negative and disobedient behavior in toddlerhood and adolescence. And again, very similar individuating is happening in each of these times, right? So babies are naturally pro-social and they become gradually more pro-social until about the age of 2 or 3. And then there's a big dip in pro-social behavior. So we see a lot of negative behavior in our toddlers, and that is expected. That is okay. They're exploring, individuating. They're for the first time separating from their caregivers. And so that's okay. Adolescents too, right? So we want kids to leave the nest. We want them to sort of become adults. Evolutionarily, that was important. And so kids start to say at this time, I'm going to think about how I want to live my life, a little bit different from my parents. And often that involves sort of testing limits, exploring, taking some risks. And so that is expected. So when we're looking at what rises to the threshold of ADD or ODD, sorry, we want to think about how severe is this behavior, how often is it happening, and how much, most importantly, is it functionally impairing the youth. So here's the actual DSM criteria. So like I said, we have these 3 categories: angry, irritable, argumentative, defiant, and vindictive. You have to have half of the 8 symptoms, so at least 4, and it can't just be with your sibling. So we pretty much assume you're going to be argumentative, irritable, maybe even spiteful and vindictive with your sibling. So it has to happen with someone else. It can be a caregiver. So unlike ADHD, which has to occur in multiple settings, ODD does not have to occur in multiple settings. Most commonly, ODD is predominantly in the home environment. And it has to be at least 6 months, so a long-standing pattern. And then just to review the symptoms: angry, irritable, losing temper, being touchy, being angry, argumentative, defiant, arguing, defying to comply with requests, annoying others on purpose, and blaming others. And then vindictiveness is just being spiteful or vindictive. There's a caveat on that one. You have to do it at least twice in the last 6 months, so more than just once. It has to be associated with distress and functional impairment, or functional impairment, and can't exclusively occur during another psychiatric disorder or substance use. And then you can't meet criteria for DMDD. I'll have another slide on this. There's a note from DSM, this is probably the vaguest part of the diagnostic criteria, that sort of says, the persistence and frequency matters. Make sure it's outside normal limits, but they don't give a ton of guidelines on what's quote normal. At a minimum, if kids are under 5, you have to have behavior problems on most days. And if they're over 5, at least once a week. And they sort of give this vague note that you should consider what's normative for developmental levels. So if a kid is at a toddler developmental level, you might expect a lot of oppositionality, gender, and culture. Notes on DMDD. So if you went to my pediatric bipolar lecture, you know the sordid legacy of DMDD is sort of being this offshoot, a desire to curb inappropriate pediatric bipolar diagnoses. But when you read the criteria, it's a lot like ODD. So it's essentially a persistently irritable mood with these developmentally inappropriate outbursts. So there's a lot of overlap with the angry, irritable subcategory of symptoms for ODD. We differentiate based on how intense the outbursts are and how pervasive that irritable or negative mood is. So the negative mood, even if this kid gets their way, they should be upset. They should be irritable. And the intensity of the outburst is important. If, per DSM, both DMDD and ODD criteria are met, we only give the DMDD diagnosis. It sort of supersedes it. I will say, there are those who believe that DMDD is probably just a more severe form of ODD and might not need to have been categorized as a mood disorder. And I think there are those that believe angry, irritable subtype symptoms of ODD are representative of a mood disorder. I'm not sure there's one right answer, but I think it is important knowing that there is a relationship between these and that we're not giving both diagnoses at once. We're trying to focus in on which is more appropriate. Okay, in terms of clinical course, we're going to see throughout conflict with authority as a problem in ODD. A lot of kids, and this doesn't mean that they're budding sociopaths, will justify their behavior and not have great insight. Maybe they're blaming others. That's okay. Symptoms usually begin early in life at home, and then a marker of symptom severity is progressing to include school and other authority figures. So like I said, unlike ADHD, we're not saying it has to happen at school and at home. The prognosis is actually pretty good. So about 2/3 of kids diagnosed with ODD will no longer meet criteria within 3 years. With that said, 30% will go on to develop the more severe form, conduct disorder, and 10% will meet criteria for antisocial personality disorder, which is sort of the one-up on conduct disorder for adults. The point prevalence is 3.3%, but the lifetime prevalence is even greater, more like 10%. We are usually diagnosing this around 6 years of age. With that said, it is a valid diagnosis in preschoolers, and I would say preschoolers onset then is associated with more severe symptomatology. It's slightly more common in boys than girls in middle childhood, though pretty close to 1-to-1 in toddlerhood and adolescence. This is more commonly diagnosed in marginalized groups, so those of socioeconomic disadvantage, those who are Black, and those with IDD. A child psychiatrist, Rupi Lega, wrote a good article in 2025 that was published in Pediatrics. There were no bad kids, an anti-racist guide to ODD. That was really interesting if you want to read more. Her concern is Black kids are 35% more likely to be diagnosed with ODD, and that disparity is even more prevalent in places like child welfare and juvenile justice, where we already have an overrepresentation of Black kids. So I think it's really important whenever we're giving more subjective diagnoses to be thinking about our own biases. And then, as I'm going to discuss, when you're looking at sort of the whole formulation of the kid, looking at behavior has a role. How did we get here? What is a child trying to communicate with their behavior? And looking at through a compassionate lens instead of a reactive one. Disruptive behavior is distressing. And so I think a lot of times our reaction is to come back with harshness, or to say almost callously, sort of like, that's behavioral. That's not a mood disorder or something like that. I hear that said. Sometimes this comes up in schools in terms of designation for services and stuff like that. So I think just trying to focus on a compassionate lens and checking your own bias as you're evaluating children. All right, comorbidities. This is probably the most controversial thing about ODD itself. This is the other thing people are fighting about. So comorbidities are almost universal. There are those that believe ODD is more of a construct than a diagnosis because it often just always goes with something else. ADHD most commonly. So ADHD is 10 times more often than expected. So if you know the prevalence of ADHD, that means over 90% of kids with ODD are getting an ADHD diagnosis. So it's sort of part of this. The rates of mood disorders and substance use disorders are also elevated. Mood disorders 7 times more likely to occur in kids with ODD, which makes sense given those angry, irritable symptoms. And again, the people that are arguing that DMDD should be a mood disorder, they're sort of part of that camp. And then substance use disorders 4 times more likely. Angry, irritable symptoms predict later development of mood and anxiety disorders. Screening. Most of the time, because of the overlap with ADHD, I'm sending diagnostic Vanderbilts and looking at the ODD section. If you wanted to do a longer screening sort of in your office, the child behavior checklist is more comprehensive, but it does take a while. The CARS 3 also has ODD questions. Differential. So I'm going to have a whole slide on ADHD and ODD, given the special relationship. I would say the diagnosis I'm most often replacing ODD with is something trauma related. So trauma can create a chronic hypervigilance in kids that can look like disruptive behavior. But I think it's really important to think about what's driving the disruptiveness. And certainly these things can go along together. Kid can have a history of a trauma, but then a pervasive pattern of oppositional behavior that meets ODD criteria. But I'm always looking at the ABCs of the behavior. So the context in which this is occurring, what's bringing this on? Can we find sort of thread or consistency? Is there something that's reactivating this traumatized brain? Things like that. So that when kids are going into a flight or fight mode, it's not because of this willful defiance that I would expect with ODD, but because sort of a loss of control in the moment. I also think that kids who have been traumatized, often there was an adult involved in perpetuating this, either through neglect or direct abuse. And so sometimes we can have complicated relationships with adults in our lives. And so that can present as oppositional behavior. And it might represent a true ODD diagnosis, but again, we have to look at in a compassionate way where this is coming from. Anxiety is similar. So I will see a lot of kids with anxiety who they're avoidant. They don't want to do things because of the anxiety, and they will get labeled as ODD because they are sometimes even externalizing. They're so anxious they might become aggressive. If, say, they're really anxious about school and somebody tries to send them to school, then they're, having a big disruptive meltdown. I'm always looking at, is the anxious behavior in isolation to certain anxious provocation. So if the things that make them anxious is the only time they're disruptive and the rest of the time they're not, that's less likely to be an ODD. Substance use disorder similarly can be comorbid, but kids might lie, they might sort of get around rules to try to obtain the substance. And so I want to see, is it primarily in order to get the substance or more pervasive? Conduct disorder, like I said, is sort of a more severe form of ODD we'll talk about in the second half. DMDD we've discussed. Major depressive disorder, similar to anxiety, kids might not want to do a lot and they might be quite irritable. So I want to look at the episode. So is the onset or time course of these symptoms only within depressive symptoms, or do they exist separately? Same with bipolar disorder. So you might have oppositional behavior that's in the setting of a depressive or a manic episode. For it to be a disruptive disorder like ODD or conduct, I'd want to have it sort of present all the time regardless of mood. Same for psychotic disorders. If it's only happening when they're psychotic, then we might attribute this to the psychosis itself. With that said, kids who go on to develop schizophrenia sometimes will have this prodromal period where they have an increase in disruptive behavior. So sometimes that's in the mix and something I'm considering. All right, so talking about ADHD and ODD. There's a lot of overlap, obviously. When I think of just ADHD alone, kids will avoid things they might find difficult, but it's more avoidant, forgetful, and then they become frustrated. Whereas ODD itself, I would think more of this willful defiance or a premeditated spitefulness. Compared to kids with ADHD alone, kids with both ODD and ADHD are more explosive. So they're more likely to have impulsivity, higher rates of aggression, and then a lot of comorbidities. Learning disorders, substance use, and they're more likely to go on to develop an antisocial personality disorder. So if I'm treating ADHD and I'm getting an unusual response, like maybe I'm not having a great stimulant response, or I'm having a stimulant response but only in certain settings or times of day, or I'm still having a lot of impulsivity despite the stimulant, I might consider, is there a comorbid ODD going on here? Oops. Skip? Yeah, okay. Risk factors. So this is where I start doing my biopsychosocial soapbox. So we do see an interplay between these biologic, psychologic, and social factors all coming in together to set a kid up to develop ODD. It's not one thing. So oppositional behavior can cluster in siblings and biologic relatives. The genetic studies are mixed, and not surprisingly, because ODD has so many comorbidities, it's really hard to separate. If over 90% of the kids also have ADHD, how do we know if genetic factors are ODD specific? There has been some interesting study on male sex hormones and aggression. There was one study with DHEAS, which basically they checked levels and they compared the child behavior checklist done by parents, and the levels were more predictive or more likely to be consistent with who had an ODD. Well, sorry. They differentiated better an ODD from an ADHD diagnosis than the parent reports. So there does seem to be biologic predisposition, but it doesn't tell the whole story. Psychological factors are also important. So we can think of kids that have a difficult temperament. So personality-wise, they're more emotionally reactive, they don't adjust as well, and they're more sort of this touchy, irritable, sort of like that subtype of ODD. Having that sort of personality style is not predictive alone. You seem to have an additional stressor contributing. For a while, there was the thought that we could solve all of this through attachment theory. So how kids had attached to their caregivers could explain why they might have a difficult relationship with authority and why they can't self-soothe in the way that ODD kids do. But we see an association with insecure attachment in school-age children, but not in preschool-age children. And preschool-age children have more severe form of ODD, so that doesn't seem to be the whole story. Social factors are important. So I think of a bi-directional relationship between the temperament of the kid and what the parent is going through. So say you have a parent who's depressed, they're already depleted, they might be a little more hands-off and not be giving that sort of positive, compassionate interaction with their kid. The kid might, in an effort to draw more attention, positive or negative, then sort of up the ante on their oppositionality, knowing this draws the parent in. The parent then might become more withdrawn or even harsh or coercive. That might then increase oppositionality in the kid. And so we end up in this sort of vicious cycle. And so when all these things are combining, say you already have your own trauma, or you were brought up with harsh and coercive parenting, you're at socioeconomic disadvantage, you're working multiple jobs, and then you have your own mental health issues with depression, and then you end up with a kid with a difficult temperament, it's going to be hard from a resource perspective to be able to provide the additional positive support that kids with ODD really need. Okay, moving on to treatment. So the goal is to reduce the frequency and intensity of symptoms. It's not necessarily we cure this, right? Though, we did talk about 2/3 of these kids are going to outgrow this behavior. We want to prevent progression to conduct or antisocial personality disorder. The earlier we are addressing this with treatment, the more effective. So ideally before age 9. Psychotherapy is number one. So more than any psychiatric disorder, I'm going to say this about ODD, there is not evidence to support that ODD symptoms themselves respond to medications, which is sort of puts me in an interesting position, right? So I think people now think of psychiatrists sort of as medication prescribers. And so the number one reason people are sending kids to me is not going to respond to medication. So it's true. So, but most of the time there are comorbidities. So I see the role here for psychiatrists as sort of examining, how do we conceptualize this kid? What are the comorbidities? How do we look at the root of this behavior? How do we hook up with psychotherapeutic treatments? And then treating the comorbidities themselves pharmacologically, particularly with ADHD. When ADHD is comorbid, ODD symptoms themselves improve. So emotional reactivity, oppositionality go down when we control the ADHD better. This is especially true of stimulant treatments, and to a lesser extent, atomoxetine, guanfacine, and clonidine. Moving on to therapy. So the big picture for ODD treatment is we focus less on discipline and punishment and more on positive, effective communication. So parent management training is the psychotherapeutic sort of set of modalities with the greatest evidence. There's a lot of different types. So PCIT sort of is all the rage in Delaware, not necessarily true in other places. So if you're working other places, PMTO might be big. The central tenet of all these therapies is the same. So it's rooted in social learning theory. The goal is positive feedback and building that rapport between the parent and kids. So you want to build up that relationship and enable the family to give effective instructions. So PCIT is very protocolized. You have this sort of relatively long course of child-directed interactions. So we're letting the child lead, and then parents sort of take over later on as they are empowered by this more positive relationship and they're better able to sort of speak to their kids in a positive way. It works very well. There are some limitations. PCIT in particular was developed mostly for the age of 2 to 7. And so if I'm saying ODD usually is onset at 6 years, it has been adapted for the 7 to 11 model. But again, it's not going higher than that. So for our older kids or adolescents who are being oppositional, it's not a great option all of the time, depending on which modality you're using and whether or not it's been adapted. A lot of parents, because of the time commitment, don't finish PCIT is another issue that comes up. And then for the most dysregulated, dysfunctional families, like say there's caregivers that really don't communicate well, or there's significantly different parenting styles, or just a severe parent-child relational problem, PCIT is less effective, and parent management training in general. All right. Moving on to conduct disorder. So conduct disorder, like I said, is a more sort of severe of these two. Criteria is much simpler. It's focused on violation of rules. First part, aggression to people and animals, so bullying, threatening others, initiating fights, using a weapon, being physically cruel to people or animals, mugging people, or forcing someone into sexual activity. Destruction of property with or without setting fires. And you need 3 of these, and at least 1 needs to be present for a year. Deceitfulness or theft, breaking into someone's house, conning people, stealing things without mugging them, and then serious violations of rules. So when we talked about ODD and how there was sort of room for cultural interpretations, there is none of that for conduct. So you have to stay out all night when you're 12 or younger, run away from home overnight, and then be truant from school beginning before age 13. So the biggest difference is the problems with emotional regulation are not included in the diagnostic criteria for conduct disorder. And conduct disorder is pretty consistent across different cultures, whereas ODD, this interpretation of externalizing behavior, in certain cultures, externalizing behavior is really unacceptable, sort of can change how people diagnose, especially if you have cross-cultural relationships between the evaluator and the family. When you meet criteria for both ODD and conduct, you can give both diagnoses, though we sort of think of them along a spectrum. Most kids with conduct start out having ODD. With that said, like we talked about, most kids with ODD don't develop conduct disorder. Most of our research for risk factors sort of lumps them together and is focused on how do we prevent that progression into conduct. Okay, clinical characteristics of conduct disorder. The lifetime prevalence is 5%, so less common. There is a significant gender discrepancy, so it's 3 to 4 times more likely to occur in boys than girls, in contrast to ODD. Some clustering families, but we don't have a clear genetic relationship. There is an association with low socioeconomic status. ADHD, anxiety, and substance use are highly comorbid. So mood slightly less so than it was for ODD, interestingly. Comorbid psychiatric disorders, particularly anxiety, are more likely in girls with conduct disorder than boys. So now I'm going to go through sort of biological, psychological, and social risk factors for conduct disorder. And again, kids who are at the point of having conduct disorder symptoms, they did not get there from one thing. There is a relationship between characteristics of the kid and their experiences. So genetic and environmental risk factors are coming into play. There's been a lot of thoughts about monoamines. So these are our neurotransmitters, serotonin, norepinephrine, and dopamine. A low monoamine oxidase A, so an enzyme that cleans up those neurotransmitter activity, is associated with an increased risk of developing conduct. Serotonin in particular has been singled out as possibly having a role. So low CSF levels of 5-HIAA, a serotonin metabolite, has been found, and then high blood levels. In terms of physiologic markers, there's been a lot of focus on cortisol and low resting heart rate, particularly in the callous, unemotional subtype of people with conduct disorder. So there's a subtype of conduct. These individuals are less likely to have comorbid anxiety and more likely to sort of commit aggressive crimes. One might say these are markers for future psychopathy. So these are people who have really poor response to punishment and are more likely to create sort of novel ways of pursuing risk-taking, if that makes sense. So there's this drive to really engage in risky behavior. Usually they have a low resting heart rate and lower cortisol. And so there are thoughts about this, but again, this is not sort of diagnostic or something that we're using as, including someone as having the diagnosis. It's just sort of a factor that's been found to be associated. In terms of functional neuroimaging, regions of the brain implicated in reward-based decision-making, not surprisingly, are implicated. There are some maternal factors. Smoking during pregnancy in particular, independent of ADHD, is a risk factor for developing conduct disorder. All right, moving on to psychological and social factors. There is a complex relationship between low IQ and antisocial behavior. This is not sort of a direct correlation. Clearly, as IQ gets lower, risk for conduct disorder does not go up. But it seems that in certain people with a low IQ, deficits in verbal abilities and executive dysfunction, there is an increased risk of antisocial behavior. Independent of low IQ, executive dysfunction is a risk factor. And then deficits in social cognition, particularly if you perceive others as hostile, which is something that happens a lot in people who have been traumatized. Social factors are huge for conduct disorder. Abuse in particular, also sexual abuse. So individuals who suffered sexual abuse are 12 times more likely to develop conduct disorder. Poverty is a risk factor, but so is proximity to poverty. So if you live in a neighborhood with poor housing, community violence, and gang activity, you'll have a significantly increased risk of developing conduct disorder independent of your actual family unit. Association with deviant peers is huge. So the vast majority of crimes committed by juveniles are happening in groups of 2 or more. And then if your deviant peers are gang members specifically, then your risk goes up even more. So again, whenever you're seeing a kid who's having disruptive behavior, particularly if it's escalated to conduct disorder, we always want to be thinking about what has happened to this child? Can we compassionately look at, this is like rooted in how child guidance originally started. Can we compassionately look at the things that have been done to this child or the things this child has been exposed to and help to heal them as opposed to being harsh with discipline? Okay, outcomes. Protective factors are being a girl, having a high IQ, and having good interpersonal skills. In terms of adult outcomes, 40% of kids that have conduct disorder do go on to develop antisocial personality disorder. Even those that don't have significant functional impairments in relationships and work. And it's hard to say, are the sort of functional impairments related to this fallout from having had conduct disorder as an adolescent? So say you were in juvenile detention or you didn't attain, you didn't finish school, let's say, or you weren't able to find employment because of conduct disorder problems. It seems that there is an independent risk factor for substance use and other psychiatric disorders. And so we think this is probably a combination of all these things, right? So the independent risk for conduct disorder, the risk for other psychiatric disorders, and the functional impairment because of all of those things together. Pharmacologic treatment for conduct. So I'm slightly more guarded than for ODD. In ODD, I'm saying there is no medicine that's going to treat ODD directly. For conduct, I'll say medicine should not be offered first line. In cases of aggressive behavior that's not responding to psychosocial treatments, risperidone has the best evidence meant as a short term. So compared to risperidone for, let's say, aggression in autism, the evidence is meh. It's not quite as strong. And compared to, say, pediatric bipolar, where I'm telling you, these kids will likely require maintenance therapy, that's not necessarily true of conduct disorder. There is no clear evidence for other atypical antipsychotics for conduct alone. With that said, often if kids are coming to psychiatry or they're in your practice and they have a conduct disorder diagnosis, they probably have something else. And so it's not to say that kids with conduct won't end up on medications. We just want to be deliberate with our selection and thinking about, okay, how am I conceptualizing this kid? What else is going on? What else could be contributing to or driving these conduct symptoms? Other medications with some evidence for aggression, specifically in conduct disorder, lithium, clonidine, and propranolol. In terms of psychotherapeutic treatment, similar to substance use, like the DARE model, shock and one-time interventions might actually exacerbate things. There is some evidence for parent management training, particularly PMTO and group parent behavior therapy. Multisystemic therapy is sort of the gold standard treatment. This is rooted in this idea of these circles of influence on a family and child with conduct disorder. So the idea that the school, the neighborhood, the community, all these things are contributing to the development of conduct disorder. And so it's highly specialized, home-based, intense, 3 to 5 months of, multiple times a week in the home, comprehensive therapy. So hard to sort of find necessarily in the community. So previously, like when I worked in Virginia, we did not have multisystemic therapy. We were usually doing functional family therapy because that was available to us. It is a viable alternative to residential treatment. It's complicated in the finding a clinician and the actual training and intensity of resources. Functional family therapy is similar in the intensive outpatient setting and it's more focused on the family itself as opposed to the spheres of influence around the family. It has some evidence, but then there's been some other studies that have questioned the evidence specifically for conduct disorder. So I'd say multisystemic therapy would be preferred, but functional family therapy also an option. All right, summary points. Disruptive behavior is a common referral concern. We expect negative behavior as part of development, and we look at ODD by how severe and frequent these behaviors are. ODD and conduct are sort of along a continuum. Conduct is more violation of societal rules. screen for comorbidities. We want to treat those. We want to look at sort of the whole context for this kid, particularly ADHD, that can reduce disruptive behaviors. Prevention and therapeutic treatment programs exist. They're usually focused on parent and child skills training. Medications are not recommended for ODD, but could be considered for aggression if psychosocial treatments are not effective in conduct disorder. And here are my references.